advice from Stephen Hay, from Wal Kalade and from Victor Adebowale, both of whom had to leave at lunchtime. Has anyone got any declarations of interest that need to be added to our registers? No? Good. Can we just start by approving the draft minutes of the meetings held in common on the 24th of May? Any comments or corrections to those minutes? Excellent. We will take those as approved. So if we can move to the first item of the agenda. Where's Pauline? What we'll do, if Pauline, then Matthew, and then is it Elizabeth rather than Paul, just give us an overview of the winter, the operational, and then the finance issues, and then we'll open it up for discussion. Pauline.
Okay, so I'm going to start by talking to the paper on winter. And I think most people will have had an opportunity to read the paper and will be pretty up to date on the various issues within it. But just to highlight a few, I think first of all, reflecting on last winter, in an earlier meeting we discussed the winter review, and that has since been published. So clearly we've taken the learning from last winter and incorporated it into our planning for the months ahead. I would like to take this opportunity to remind people that despite the challenges that have taken place last winter, the NHS actually managed to see 68,000 more people within 4 hours during that peak winter period. And I think the reason why I'm making that point is that I think it's really important that this meeting, and indeed any similar meetings, takes an opportunity to thank our staff for the tremendous work they did, and that they see some headlines on those issues as well as on the challenges that they faced. Just to bring people up to date and to say that an enormous amount of work has taken place across the NHS since last winter, with a significant focus on transformation. All members of the board will be very much aware of the vision for the future as far as the delivery of urgent and emergency care is concerned, and having a very different model to the model that we've sort of all grown up with. And in the last 6 months and more, there's been a real focus on the component parts that we need to get in place to deliver that vision. So just to highlight a few, they are set out in the paper. But for example, if we look at our 111 service, the number of calls being handled each month have grown significantly by about 10%. Really importantly, over 51% of those calls are now being dealt with by a clinician. If you remember, we had an ambition for 50%, 100% coverage with 50% of our calls, and we have managed to exceed that. If we move to what happens within hospitals, we've set up GP streaming in all emergency departments across the NHS, where we feel patients can benefit by having GP streaming, where patients with minor illness are arriving. And we've also made real progress in developing emergency daycare, an increase of about 10% year on year. Within the hospitals, we've had a significant focus on length of stay, which is very important to us moving forward. And not only have we managed to reduce the number of beds on the back of our detox work by about 2,200, which is equivalent to a number of acute hospitals, depending on the size of them, but also on our length of stay work for patients who've been in hospital for longer than 21 days. We set ourselves an ambition around 4,000 to reduce it by 4,000, and so far we have reduced it by the equivalent of 1,697 beds. Outside hospital, we've had a significant focus on preparing for winter as far as GP access is concerned, extended access, and that will be in place by October. Our ambulance service is working through its own transformation programme. The new standards have been implemented across all ambulance services, and month on month we can see an ongoing improvement in each of those standards. As far as workforce is concerned, we've had a particular focus on our ED workforce, an increase in consultant numbers, an increase in physician assistants, and an increase in trainee doctors. As well as those areas of transformation, we've taken a number of specific actions in order to prepare for the winter period. The first one to highlight, again set out in the report, is the work on flu. I don't think I need to remind anybody around the table about the challenges that we faced last winter. We made a very early decision this year about the vaccine that we would use across our general population, for elderly people and for our younger citizens, using quadrivalent for our younger citizens and the adjunctant trivalent vaccine for people over 65. And again, we've set out in the paper the impact we believe that would have, as well as increasing the distribution of vaccines to children. We've spent a period of time working with professional organisations, trade unions and our staff to talk about how we can deliver an ambition of 100% vaccination cover for our staff within the NHS. And we are launching a programme about that as we speak. Other specific actions to support winter, we've put 145 million into our hospitals and some of our community services to increase bed capacity, to increase capacity to support emergency daycare, etc. We've had a significant focus on our elective programme to monitor very carefully what is happening with patients who are long waits, 52-week patients, 52-week plus patients, but also on the full programme, so as to avoid a situation occurring where we have to have short-term cancellations or short notice cancellations this winter. So a lot of work taking place there. We've also had a significant focus on our poorly performing organisations, identified who they are, and we've been working intensively with them over the recent months. And in addition to all of that, we are putting back in place the same arrangements that we had last year from a national, regional, local focus to support our frontline staff. So I think that gives a very quick summary of the work that has taken place on the transformation front and on the specific actions that we are taking to prepare for winter. Clearly, we recognise that the coming months will be a challenge. We are concerned about the level of occupancy within our hospitals, and we're particularly concerned about the ask of our staff. We know that they've had a very difficult year during the summer months. The heat wave caused us problems as well as the cold weather in the winter, and we know that people have had to work long hours, etc., to support the care that we want to provide for our patients. But I think that's enough from me for now.
Thank you, Pauline. I think we would all want to put on record how grateful we are for the work that people across the country in the service are doing in what we recognise is a very pressured time, that there hasn't been much of a let-up through the summer at all. And we know how hard people are working to deliver the standards of care that they want to deliver and that people expect. We also recognise how hard you and your team are working, both in NHS England and at NHS Improvement, to support them. So thank you. Matthew, do you want to take us to the operational performance?
Yes, let me just pick up the other areas beyond emergency care for you. The numbers are all in the paper, so I won't walk you through those. Let me just talk a bit about sort of the headlines. So around waiting lists, we set ourselves a target of maintaining waiting lists at its current level and reducing long waiters. We have seen an increase in the waiting list so far this year and an increase in long waiters. So through the regions, we're working with every hospital to put in place the processes to ensure that the number of patients waiting more than 52 weeks are reduced back to half it, with an ambition to reduce it back to zero. So putting in those sort of rigorous processes are going on at the moment, and we're working through with hospitals how we increase the volumes of activity that are being done, recognising the pressures that are on beds that Pauline talked about, but the need to make sure that patients aren't waiting unnecessarily for outpatients, aren't waiting unnecessarily for day surgery, which are not curtailed by access to inpatient capacity in order to manage the waiting lists back down. In cancer, we got within touching distance of the 85% target at the end of last financial year. So it was with considerable frustration that we saw that, that our compliance has fallen to 78% on our 62-day wait cancer target. That is being driven by a very large spike in demand through increased public consciousness, particularly around prostate urology cancer. In February, there was much news about that had become the major cancer killer above breast cancer, and that led to something like a 14% increase in the total number of cancer referrals, something like a 26% increase in the number of urology referrals, so which has caused this extension in waiting times. Now, we would continue to encourage the public to come forward if they suspect that they may have the symptoms of cancer. It is very important that we screen and identify early, and therefore the challenge for the NHS is to make sure that we can respond to that growth in demand appropriately. So we currently have distributed, process of distributing £10 million in order to, across the NHS, to deal with the backlog that was created by that, with that increase in activity, whilst we continue to make sure that best practice in focusing on every patient on a cancer pathway is happening in every one of our institutions, and working to make sure that the best practice pathways are put in place across the system. And the last thing I would just touch on is on our mental health programme, where in terms of our ambitions around the 5-year forward review, we are making good progress and are still expecting to hit the objectives. But we are also looking now at making sure that the work around mental health is also supporting in the run-up to winter, supporting the whole of the system to ensure that patients who have mental health problems don't find themselves lengthy times in A&Es when they should be more appropriately being cared for somewhere else. So there's both the where are we going to be in the next 2 or 3 years, and where do we need to be in the next 2 or 3 months in order to make sure that the winter flows well. Thank you.
Thank you. Elizabeth.
Yeah, so before we come on to the financial consequences of the performance discussion we've just had, I think it warrants just for noting that this is the first time, it's just a pleasure actually, but this is the first time that NHS I&E have actually prepared a joint finance report that looks holistically across finance, across both commissioning and provision. That's not been without its challenges, mainly because there's some technical different ways in which we report, and we can always, pick some of those questions up offline, or I can ask Paul to explain. But what I would like to do is just give you a brief update about where we are in terms of the planning process, and because clearly at our last joint board meeting we committed to working with the sector to ensure that we delivered a balanced plan. So the last time we met, we were talking about having a 3-stage process to improve the planning position for the sector in aggregate. A lot of work has happened and good progress has been made, but throughout that process, and as that work has happened, both at a system level and bespoke discussions with individual trusts in particular that were the most challenged, we have also identified a number of other risks. So some of those would be expressed around some of the challenges coming back about the agenda for change discussions that we're currently having with the service, and making sure that that commitment is fully funded. And equally, we did not expect to have had at this stage of the year some of the occupancy issues that have been more eloquently described by Pauline and Matthew. So where we stand at the moment is we've closed more than at least half of the gap. The work continues, and there is an absolute strong commitment across I&E and the service actually that we need to close this gap before Q2 and go on to deliver this balanced plan, because most importantly, this is the platform for the long-term plan. And if we end up in a position this year where we have any financial risk that needs to be carried forward into future years, obviously that will affect our ability to really drive change. And that really is important, and something that we're really getting back in spades from the work stream leads. So as at month 4, table 1 within the report, summarises the position. So we're largely on plan, or broadly on plan. There's further work to do in terms of closing the planning gap. But I think we can say that it's a positive place to be in at this stage of the year, in respect of the fact that the board approved plans that have come forward from all of our providers and the commissioning sector are in aggregate being delivered. So I think that's a really positive thing to say. It is of course not without its risks, and we also highlight within the report there is a level of risk which, whilst we have much greater clarity on the risk and a better understanding and it's more triangulated, we no longer have a risk reserve to offset that risk. So between now and the end of the year, we are going to be looking at a number of options and us working with systems really to say, what are the trade-offs to ensure that we don't forfeit some of the future by making bad decisions this year.
Thank you very much. Can I open up the discussion? Looking down the long line of people. No additional comments? Everyone happy to take those as read? Ian, Simon, nothing from either of you?
Yeah, I wonder if it's worth saying a little bit about the importance of the flu vaccination programme.
I think that's a good idea.
As part of our winter preparedness. I think the general story is, as Pauline outlined, that that this has been a tough demand year and occupancy is high, but against that there's been an awful lot of transformation work, and the NHS is putting a lot of cash out there to help those places that need it with new capacity. So there's a lot of good planning going on. I think the NHS faces the winter with an awful lot of effort at local, national levels, but as part of that, ensuring that our staff are protected across the winter and able to support patients through vaccination is really important. So at the risk of putting one of my fellow directors on the spot, I don't know if, Steve, whether there's we've clearly had seen the importance of this in our winter plans, and I wonder if you wanted to say anything.
Yeah, so of course there's 2 components to flu vaccination. One is the vaccination programmes that we run with Public Health England for the general public, and the other is the vaccination programmes within staff in those institutions that deliver healthcare. So on the former, I think one of the things to say for the coming winter is that we have a new vaccine. So we have a better vaccine for the over 65s, and the Joint Committee on Vaccination recommended its usage with guidance subsequently from PHE, and we alerted our general practitioners and commissioners to that earlier in the year, and we have been working on the distribution of that new vaccine, which is always, because it's a new vaccine we haven't used before, it always requires a fair amount of planning, so that is being distributed out, and that will give a better level of protection to those particularly who are most vulnerable. So we're very keen that particularly our over 65s have access to that vaccine. On the staff side, we all recognise as professionals, in fact it is in professional guidance that we have a duty to protect patients through avoidance of things such as transmissible common illnesses, and we've worked really closely with our professional colleagues this year. That's colleagues such as Kathy, Ruth and Jane within NHSE, but also our chief professional officers, which cover many other professions, allied healthcare professionals, pharmacists, etc., and with our colleagues outside NHS and NHS Improvements, our Royal Colleges, the Royal College of Nursing, and many of our union partners, to ensure that we deliver a consistent message to our staff that it is really important that staff are vaccinated, that vaccines are effective and they're our best way of protecting. And when you don't initially have symptoms, you are still in a position where you may be able to transmit the disease to colleagues and patients. And we put a particular focus on those areas where our most vulnerable patients are treated. So those would be patients whose immune systems, either through disease or through treatment, is compromised and may be particularly susceptible to flu. And we've asked our medical director and nursing director colleagues in our providers to ensure that staff in those areas are vaccinated, and if they're not, to look at the possibility of whether redeployment is required. Obviously balancing everything that one needs to balance in terms of the safe running of those units. So I would like to emphasise, as I'm sure my colleagues around the table would, the critical importance of vaccination amongst staff this winter, and we are really focused. And last year we did better than the year before, but we know there are some institutions that could do even better, and we have a real focus on that this winter.
Jane, you wanted to come in?
Yeah, just to build on what Steve said. So, yes, last year we had 68.7% of staff that were vaccinated, but I think the really critical fact that we've done a lot more detailed work on this over the recent months is that 30%, over 30% of people can have flu, carry the virus without actually knowing they've got it. And if that's a member of staff, whatever job they do, who are in contact with people, whether that's in a general practice surgery, whether it's in a hospital outpatients, whether it's in a ward, that really does put people at risk. And so it's absolutely vital that staff do take up the vaccine. It is effective. And we are very clear that we need to make that as easy as possible for staff. So it should be easy for them to be able to have that vaccine. And I think we know that a lot of the organisations who delivered very high percentages last year did that. They made it very easy for people to have the vaccination. They were available, throughout the different times of the day and night. And I think that's another critical part of this.
Matthew.
Just one further point. Knowing the many millions of members of the public listening to the live stream, it would be remiss not to mention that for the second year running, the NHS is extending the free vaccine to social workers, people working in care homes, people working in nursing homes. Don't just protect yourself, but protect the people that you're caring for. And if you bring a proof of identity of where you work to a pharmacist or to your GP, you will qualify for free vaccines as well, and getting that message out is important.
Yeah, indeed. Maura.
I was going to make a similar point in relation to social care sector, but I hope that we will basically pay attention to what the level of take-up is in social care. It's obviously taken some time to build up even that level in the NHS staff, and of course there's a much more dispersed staff group and the messages again should be thinking about how they would be communicated with as well.
Fantastic. Well, I'm sure we are all looking forward to getting our flu jabs as a board in very near future.
Can I just say, last year the board of NHS England had a 100% success rate on flu vaccinations, and we're looking for these behaviours to be modelled with our new board members.
We accept the challenge.
Good,
Exactly.
Fantastic.
Exactly. I have to say how encouraging it is. I know how challenging the circumstances are, but it is so encouraging to have these joint reports and a shared view of our preparation for winter, our operational performance and our financial performance. It's a huge step on, actually, even since May, when we last all met together. So thank you. With that, I will hand over to my co-chair.
Well, thank you, Dido. The next item on the agenda is the long-term plan for the NHS, and I should just, I think, point out for those who are observing the meeting that all of us this morning have spent some time trying to get to grips with this and the complexity of the work streams and the public engagement and stakeholder engagement processes that have been undertaken. So with that background, I think it's very useful to invite Simon to introduce the theme, and then, if I may, and turn to you for further comments. But Simon, over to you.
Okay, thanks, Malcolm. As you say, we have had a chance to have quite a good discussion on the substantive process and content points this morning. This is obviously a work in progress. So really just to say three things. First of all, remind us all that the starting point for the long-term plan is an objective assessment as to how well the NHS is doing on clinical quality outcomes and the health of the population. And we're working with academic partners, Public Health England, to ensure that we've got a good objective baselining of that. Many third-party organisations have produced those kinds of assessments in the run-up to the NHS 70th anniversary, but that helps us frame what the opportunity looks like over the next decade. Secondly, we're starting from a position where we've got intense financial and operational pressures in the system, and therefore we need to recognise that those are calls on resourcing, on workforce in the early years of this plan period. And thirdly, we recognise that we have begun a journey of towards a more integrated care delivery system. So we're not starting with a blank sheet of paper here, but being clear about what the milestones to complete that task look like. And obviously, Andrew Morris embodies what that journey needs to look like. So we've got to reflect that position as a starting point for the plan as well. So clinical outcomes, the financial and operational pressures, the journey we've been on, where have we got to, that's the kind of baseline from which we begin the process. But related to that, we've got what I would call a sort of trifocal lens. So for some of these, if we're trying to think clearly about where we want to be as a country on our cancer performance, our mental health performance, cardiovascular disease, other big causes of avoidable illness or disability, we need to think out over a decade. The second timeline is we've got 5 years worth of funding, and we've probably got more financial headroom in the sort of third, fourth and potentially fifth years of that than we have in the first couple of years. And that is the third timeline, the here and now, when we can be much more granular about what the trade-offs and the opportunities look like for 2019-20, 2020-21. So it's kind of 10 years, it's 5 years, it's 2 years, it's that trifocal lens that we're bringing to the exercise. And that then draws me on to who the we is. There's actually been an enormous process of engagement and mobilisation. I think Ian and I want to thank the huge numbers of patients' organisations, frontline staff, trust CCG leaders, and members of the public who've been engaged with us so far. The sort of first phase of this engagement process completes at the end of this month, where the working groups, which we've set out publicly, will have developed their sort of initial propositions. Then we're using the period October through the end of November to actually shape the sort of cross-cutting trade-offs, the synergies, the challenge, the scrutiny as to what that looks like ahead of being able to publish the long-term plan aiming for the end of November. And then the third phase of the process is that given the trifocal lens, there are things that are 5 or 10 years we won't be trying to sort of be precise about nationally. There will need to be a period of local discussion, engagement, where the health service and our partners, local government, the voluntary sector, between December and April, then make that real for each of the STP geographies, and they set out how, within that broad national framework, they intend to advance the long-term plan for their populations. So we now know the date of the budget is October 29th. What that means is that the long-term plan sticking with the original timetable which we set out at the end of November will follow the budget rather than be concurrent with it. But by the time we get to the end of October, we are aiming to have done a lot of the work to think about the trade-offs, the resourcing and some of the workforce constraints, so that at least some of the sort of major themes that might emerge from the long-term plan will be available to us on that sort of timeline.
Thanks, Simon. Ian? Completely agree with that set of comments. This is something that I think exemplifies our joint working, really, in the sense that this is a joint process and ultimately a joint product, I think, on behalf of NHS England and NHS Improvement, and we are literally joined at the hip, I think, as we go through this really complex process over what is inevitably quite an aggressive timescale, but also to not miss the opportunity that this plan offers us. And I think something I would add. It's a great opportunity, actually, that this is the NHS's plan. So I think, you know, that process that Simon outlined is a planning process that the NHS, supported by the people in this room, but the NHS actually has to use to set its own direction. So this isn't a plan that sits in Simon's office or my office and comes out in November out of the vacuum. This is a plan that is built up with the process of engagement and involvement at every stage in the process that Simon discussed, and I'm particularly heartened to see that the way we're building this with a series of work streams looking both at the clinical areas where, despite offering good care, we aspire to do better over the next 10 years, and by definition that's a stretching set of conversations, and those are going on in a number of the work streams. But there are other work streams which very sensibly are looking at how we actually run the NHS, how we spend the money, and how we use the organisations of the NHS to drive towards our objectives over the next 5 years. And in all those work streams, there is very significant engagement and indeed leadership from people out there running organisations, from people providing care to patients across the country. And I think that process is critical, because that gives us a sense of confidence that this will be the plan from the NHS for the NHS. So I think that's the first point I'd make. I think the second point, just to pick up on something Simon said, and perhaps take it on a little bit. This plan, for me, you can describe it in a whole number of different ways, but I think it fundamentally has two key sets of objectives. The first is to say, how do we drive the improvements in care that we know we need to make for our populations over a 10-year period? Building on the excellent work, the excellent care that I think everybody acknowledges the NHS generally gives now, but saying we're not satisfied with that, and we know in a changing NHS we want to do better. And so I think there are a series of, of ideas that are going to come from that will set out, I think, a very compelling set of objectives that I think will be things that we will want to sign up to and make happen. But at the same time, and I welcome this second but equally important focus, we have 3.4% real terms growth to use to run the NHS over the next 5 years, and that's a significant increase in resourcing, and it's incumbent upon us, I think, to use that really wisely to deliver the maximum health gain. And so the second aspect of this is that this has to then provide our route map for running the NHS from the position it is today to an even better position at the end of that 5 years, recognising that we have to deal along the way with the issues of financial pressure, of workforce challenges, as well as the things that we do really well and we want to do even better. And so the fact that there are these two different levels in the plan, I think it seems to me to be entirely appropriate, and gives us a hope that at the end of the first 5 years we should be able to set out a route to both clinical and financial sustainability and improvement, but also set that very much in a compelling vision for where we want to be clinically in 10 years. And those two things obviously join together to provide that forward direction that I think the NHS is asking for. So, of course, inevitably there's a lot of process, a lot of discussion, a huge amount of engagement, and that will involve trade-offs, and we have to be part of those discussions and honest about those discussions. But I'm actually very excited about the opportunity we have to work together to run this planning process, and look forward to continuing discussions with people around this table over the next couple of months.
Well, thank you, Ian. Let me invite any comments or questions to Simon or Ian. David Roberts.
So, Simon and Ian, you talked about I think an important trade-off about sort of the amount of investment that's available to create new versus the making sure that we have sort of got a stable base. And one of the critical components of that, I think, is you can't change an organisation without capacity, and part of that capacity is capital. And if I think about whether it be maintenance backlogs, whether it be the technology investment that we all believe will transform service and efficiency, and I think about the need to reconfigure health systems to be able to deliver to the needs of a ageing population, for example, more in the community, then none of that is going to happen without capital. And that seems to me the missing part of the equation at the moment. And therefore I wonder if you could, Simon or Ian, maybe just talk to us about your thoughts on how you're going to manage that process with government and the Treasury in particular.
Yes, certainly, and I would say that's not the only missing part of the equation. As we know as well, what happens around public health grants and prevention, what happens around the availability of social care for children and adults, particularly for older adults, and then of course the workforce training budgets that are represented through HEE. Those are kind of four, including the capital point. Those are kind of four dependencies which are external. I think that message has been understood by those whose decisions it would be to sort those things out. But the timeline for that, some of that will be with the spending review, and so we've got to show the connections between what we're proposing in the plan and getting good answers on those topics. The Prime Minister has been very clear that the future funding of adult social care should, at the very least, ensure that there are no additional pressures arising in the National Health Service in subsequent years, and so sort of fleshing out what that means in practice and how we work together to bring that about is, along with the capital point, the training linked to the workforce and the public health piece, an integral part of this thing flying.
It's clearly important that there isn't a dislocation between ambition and plan from resources.
Exactly, which is why when it comes to, for example, the central activity modelling here, we've got to kind of connect what is kind of sort of trend, what is the opportunity cost of trend relative to investment in community health services, and how might those two kind of help balance each other off, and what are the kind of external pressures flowing into the system, of which the pressures in adult social care have obviously been enormous contributors over the last 5 years.
And just to add to that, the other general point, which I think is inevitable in a planning exercise of this magnitude, is that this is also about prioritisation. I mean, you know, we start from in terms of revenue, a certainty of where we're going over the next 5 years, and that gives us something to play with and to plan for. But just whether you're looking at the revenue expenditure or the capital expenditure, I think the incumbency on all of us as we work with the work streams and then go through this process of understanding where the prioritisation lies is to be really explicit and clear about that. And I think picking those areas I think will be important. I suppose the question I thought you were going to ask, because it's another example of where we have to understand two potentially competing pressures and probably do both of them. We also have to think about how we not only recognise the need to start from where the NHS is and build financial sustainability back in, but create enough headroom for transformation. Because across the, I thought it might be, David. So I thought I'd get out there now because, I mean, the reality is, over the next 5 years, we need to use the new money for both creating. We've got to get to a financially sustainable NHS, including a financially sustainable provider sector within that. And indeed, the paper refers to the financial tests that are essential on this. But at the same time, simply by carrying on doing what we're doing, we will be probably passing away the future. So we do have to also have that difficult conversation about ensuring that there's some scope for real transformation here as well. And clearly some of that transformation will be linked with productivity and efficiency and should actually therefore help us balance the books. But at the same time, you often need that transformation money earlier in the process than at the end of it. So all of those things are inevitably concerns that we'll have to deal with. The key is having a clear objective that we probably have to do both of those things.
Ruth and Michelle.
Thank you. I'm delighted that we've got workforce being considered as part of the long-term plan. I think it was perhaps something that was missed from the 5-year FO review, so it's a really great opportunity to have it. And Ian, Jim and Navina and myself are working hard to engage with a whole range of people. And I'm very grateful indeed for all the people that are sending me lots of emails and our opportunity to hear from them. So the big message is about what we're trying to do to develop, about how we capture the heart of the NHS and the heart of the workforce and the key actions that they're going to move the dial. So how we support our staff, how we address the supply our staff, and how we use technology is a really important aspects then to support our finances, our quality, our urgent care. So getting the sufficient workforce is going to underpin all the rest of the work streams. We can't have fantastic respiratory care or cardiovascular care or mental health unless we've got the right workforce in the right numbers and with the right skills and experience. But I guess going back to what David's point is, it's these costs associated to this that we're going to need to utilise what money we've got better, as well as considerations for priority of resourcing in the future.
Thank you. Michelle.
Thank you. For Simon and Ian, there's been a very welcome in the design of the initial stage of engagement for the long-term plan. Could you give us a sense of how that's going, and what do you think some of the key issues are at the moment emerging through that work, and what could it potentially mean for some of our most disadvantaged communities and people?
Pretty well for Simon to kick off, I think.
Okay. Well, I don't want to second guess what the group on prevention and inequalities are going to come up with. They're obviously in the process of kind of refining their propositions, but I do know, based on conversations with them so far, that first of all, there's a sort of question mark about what's happening to changes in life expectancy across the UK and across a number of industrialised countries. There are some data that ONS have published within the last week on that, showing differences within the UK, and there will shortly, I don't think I'm not going to break the embargo, but there's a very important paper coming out in the Lancet in a few weeks' time, which is going to decompose this by different areas of England, and it's got some quite... Well, I really better not say anymore, I'm going to be shot at this point. But anyway, we have access to those, early access to those data, and they're helping inform what the programme would look like. So we've obviously got decisions to make around resource allocation. We've got decisions to make around whether we build in intentionally specific inequalities reducing goals across the board and into the particular sort of clinical programmes that we're developing. And then, frankly, we've got, as we've discussed around these tables before, we've got a series of questions about whether our actual delivery mechanisms are too undifferentiated to really make a difference for some of the types of access inequalities that we see. I mean, we hypothesise that the answer to that question is yes, and therefore we've posed the challenge. So what would you actually need to do differently in each of those delivery chains if you were going to get at that inequality reduction? So those are the sorts of ways that the group is conceptualising it. Part of the October process is then getting them to challenge all of the other work streams around whether they're being sufficiently radical and whether their way of thinking about the inequality reduction is kind of going to work. And we're doing this very closely with Public Health England and with many other partners as well.
Fine, well, thank you very much. I don't see any other requests. I mean, I think we have to recall that this is an immensely complex operation, and we're all immensely impressed by the work and effort that's gone into the work streams. I'd like to actually, on behalf of our two boards, extend our thanks to all of our colleagues in our own institutions who are putting so much time and effort into this. I've had an estimate that some people are putting, as much as 50% of their time, and that's already working 150% of their time. And only with that effort are we ever likely to succeed. I think it's sobering to realise that actually in this room is the bulk of the national leadership of one of the greatest institutions in the country, if not the world. But I use the word institution in a figurative rather than a literal sense. It's not a single institution. It's not somewhere where we can sit and push buttons and pull levers and things happen. It's an immensely complex ecosystem. And much of what we do through the long-term plan has to inspire and has to lead people to a new vision of how the future could be delivered for the patients and the population that we serve. And as the great wave of enthusiasm hits the hard rock of resources and subsides into the sands of delivery, so we've got ourselves an immensely complex problem. But I hope the board feels comfortable that actually work is in hand to deliver something which will be of the quality that we need. and we will be able to engage all members of the board through the coming 6 to 8 weeks as we bring this through to final fruition. But thank you again for all of those who have been working so hard on this front. Dido, back to you.
Goodness, this co-chairing business is getting quite tough, Malcolm. Competing, rather more prosaically, we'll hand over. Our next item on the agenda is an update on progress on the Integrated Care Systems programme. Ben, are you going to take us through?
Yes, very happy to say a few words. The paper you've got in front of you is partly an opportunity, as you can see, to give an update on the progress that our now 14 integrated care systems are making. But I think perhaps more importantly an opportunity just to give a sense of how we think this connects to the work on the long-term plan that Simon, Ian and others have just talked through. As you know, at the heart of the idea of integrated care systems is the very basic principle that if we are to if we're to really get to the heart of how we do things like improve the quality of care for frail older people, for people with long-term mental health conditions, and so forth, we simply can't do that by looking at the world through purely institutional silos. We need colleagues from across general practice, community and mental health services, adult social care, acute services, across providers and commissioners to come together and essentially make a more common, consistent set of decisions about how they use their collective resources. And I don't just mean financial resources, but workforce, estates, other assets. How they design and oversee delivery of care and support services, and how all of that translates into better population health. What we've been doing, as you can see, I hope from the paper, is working with both that initial group of 14 integrated care systems and with a wide range of other partners to really try and distill what the sort of essential characteristics of integrated care systems are. And I'd really draw colleagues' attention to paragraph 7 of this paper. The framework here isn't something that we've is not a sort of blueprint that we've invented nationally. This is emerged pretty much organically from the work that those integrated care systems have done. And I think the significance of it is that when it comes down to it, most of the work involved in this new approach to resource planning, service design, population health, most of it happens at the level either of quite small neighbourhoods that sort of coalesce around primary care networks, or places covering broadly populations of 2, 3, 4, 500,000. The precise numbers don't matter. What does matter is that within those populations, you've got people coming together to really think about how you integrate care around the needs of particular groups of service users. And part of the reason we think this is so important and why integrated care systems think it's so important is that by starting to describe the practical activities that are carried out at those different levels, this really starts to speak much more to people working in clinical teams, and it also speaks much better to local government and to the type of deeper, stronger partnerships that we need to forge with local government, both to address wider determinants of health and health inequalities, and also to provide better care for people with complex health and care needs. At the same time, as you'll see from paragraph 7, we and colleagues in the service developing this approach do think it's important to have some things done at the bigger system level, in other words, broadly speaking, populations of about 1 million plus, partly because there are some decisions, for instance, about how you plan more specialist acute services, potentially some big decisions about how you manage common workforce issues, potentially some big population health interventions, and also a sort of confidence that together you are sort of best managing the overall NHS resources for that patch that are best done at that system level. But all our emerging integrated care systems are following something like that approach. Just the other thing to add is that I won't preempt the outcomes of the work we're doing in support of the long-term plan on how we put integrated care systems on a firmer and more consistent footing around the country. What I will say is that from all the engagement we've done so far, two very clear messages come through. The first is that when you start to describe the work that integrated care systems are doing in these terms, it kind of becomes obvious that everywhere should be doing this, and we are rightly being pushed to do more to avoid this being seen as an optional extra. we mustn't run for too much longer with what appears to too many people to be a kind of two-tier system. Everybody should be doing this. And the second, I thought, very consistent message is that in all of that, it's really important to make clear that these things called integrated care systems are collaborations between people who provide health and care in different settings, whether that's general practice, mental health services, acute services, and so on and so forth. And none of this undermines, in fact, all it reinforces the importance of having strong provider organisations. But in some ways, our definition of a strong provider organisation is evolving. It is no longer enough simply to provide high-quality care for your direct patients and to be good stewards of the public resource that you manage. A strong, successful provider, whether it's a network of GP practices or a hospital or mental health trust or a community trust, a strong provider also works alongside its community partners to do all the things set out here. So much more, I hope, will come from from the work we're doing in support of the long-term plan, but I think those are the two big messages coming through so far.
Thank you. I wonder if I could start by asking Andrew to comment on the paper, given your specific experience, and then go on to Joanne.
Okay, so I lead the Frimley system. It's got about 800,000 residents. It spends about 1.4 billion on health and social care. And we've developed a coalition of the willing in terms of all the leaders in local authorities and local health organisations have signed up to a joint vision and a joint plan around how we provide better integrated care that's closer to people's homes. So we're working on 3 big initiatives that we've got evidence work. So one is the integrated care teams. Hospitals can only do a finite amount of activity. So can we push more work into the community? So we've got teams of nurses with some mental health, social work support, some consultant support where appropriate, looking after the high-risk patients who the GPs think are likely to bounce into hospital. And they're providing more upstream care and keeping people in their homes for a lot longer. So if you look at the number of emergency admissions into Frimley Park, because we've wrapped this service around one of the 2 DGHs in our patch, emergency admissions for one night or more have remained flat for the last 3 years. And that's taken a load of pressure off the team at the front door. We've also put more of the decision makers on the front door, more consultants, to plug into that service and make the right call around whether we admit or discharge people. So that's one initiative. Another one has been around trying to develop the 8 a.m. to 8 p.m. offering for general practice, and that's slowly being taken up in our patch. We're having to publicise it a bit more, but it's there. We've got an offering from Monday to Friday, and in some places, some of the practices have been really courageous and tried a Saturday offering as well, and hopefully we'll work towards a Sunday service. And again, that just takes a bit of pressure off some of the kind of relatively minor conditions that the 2 emergency departments look after. The third one is around mental health services, and we've had a big success with the Safe Haven Cafe that we've got in Aldershot. Aldershot's quite a deprived area, and any resident can just drop in. It's an evening service and have a conversation around their concerns, and that's taken about 30% of activity away from the A&E, and we've got about 5,000 attendances in its first year. And we've done a little survey, and the satisfaction rate that's come back is about 85%, who thought it was superb and a much better experience than going to the Frimley Park A&E, even though the Frimley Park A&E is good. So those 3 things I think are making a difference, and we're trying to roll those out right across our patch. So in East Berkshire, we haven't got each of those 3 measures in place. And that's an area of focus. We're also looking at a different way of working with social care. So we've got a paucity of capacity for dementia patients. So the NHS is putting a bit of capital in, Bracknell Forest Council's put a bit of capital in, and we're going to provide a 70-bed nursing home facility for dementia patients. So you will be assessed, not at Wexham Park Hospital, nor Frimley. You will go into that setting, and we think we'll provide a better service, and we'll have a better chance of getting people back home rather than offering a kind of institutional care option, which often is more expensive. And the big thing that I believe will throw out lots of savings, I hope, is around the shared care record and how we lever IT and intelligence, clinical intelligence that comes from it, so that we avoid duplication and we speed up care where it's appropriate to do so. So I'm quite energised by some of the changes we've dropped in. It's not easy. I've got no power. This is a coalition of the willing. So there are some weeks I think, gosh, we're going backwards, but generally speaking, we're moving in the right direction. And the clinicians are energised because we're saying to them, you design the service. So I had the privilege of going to a discussion on heart failure. And for the first time ever, some of the consultants who've been very reticent about changing pathways were really up for, let's not have so many follow-ups. Let's try and move to a different type of service where we let go a bit and try and give, empower the patients to look after themselves rather than we keep pursuing them for follow-up appointments that have little kind of additional value. So we're trying to create a big movement. We've got an academy, leadership academy, that we've put a lot of time and effort into this. So this is not just about the top leaders having a kind of vision. It's about how can we create a whole movement where people feel that they're empowered to make changes on the deck, and those changes are meaningful in terms of improving patient experience and outcomes. And over time, as a system, we want to move to a more of an outcome delivered service. So can we make a big impact, before Simon makes the challenge, about improving mortality in Slough, because it is very, very different to, if you live in Camberley, there's 6 years difference. And I think over time we can. And I'm hoping that the NHS 10-year plan will give us that freedom and opportunity. So we can tackle some of the deficits around cancer, because if you live in Slough, the outcomes aren't as good, nowhere near as good as they are in even Aldershot, which is our next kind of deprived area. So we've got a lot of work to do, and I think liberating the clinicians will give us a better health service if we give them the opportunity to redesign care.
Well said, John.
Thank you. I mean, it's so encouraging and exciting to hear about the tangible changes that are being made through this approach. I have a sort of more prosaic question really about the alignment of governance with the delivery of real service to real people. Because we know that these new integrated care systems don't fit perfectly with the organisational structure of the NHS that we're living with now. And I speak to a lot of clinical commissioning group audit chairs, some of whom say to me, we have a legal accountability for commissioning decisions and for the way that the money is spent. And we are not sure how that reconciles with that lay governance of the integrated care systems. So you're very much aware of that as a challenge, I know. And I wondered if you could say a bit about how you envisage we might move towards better alignment of that sort of accountability on behalf of local populations with the increasing sort of dynamism and the engine of integrated care systems.
Respond, because I think it's a good challenge. So we're working to a system control total, and if someone overspends, if an organisation overspends, CCG or a provider, someone has to underspend by a compensating amount. That's created a bit of tension where you've got specific issues, but we get through them, and I think everyone's signed up to that as a principle. So that's, if you like, a check in the system around, you know, keeping control. We have also got a system-wide non-exec and lay group who act as a kind of quasi-audit committee. So they look at our objectives for this year and, you know, take a view about, are we making tangible progress against those objectives that we've set as a system. And obviously they're very interested in all the dynamics around the system control total. We've set this group up this year. We're in the kind of still in the learning kind of stages, and the challenge around, you know, the governance piece, particularly where you've got agreement in principle from chief execs to do a bit of trading in terms of one overspends and the other one underspends, and how we get respective audit committees and boards on side, because that's obviously a point of tension potentially. So we're, again, this is, you know, we're in the kind of early stages of this, but we recognise that that's a legitimate challenge.
Steve? Yes, I think Andrew's given a really powerful illustration of integrated care system, just the transformation of work it can do when it really gets going. And I had the privilege of joining Andrew and his senior clinical leaders for an evening event in the late spring, and I was incredibly impressed at the energy and the work and the projects that were underway between secondary care and primary care and other clinicians in the room. And I think it brings home to us just the importance, as you said, of liberating clinicians to find solutions, because our clinicians have those solutions and often feel constrained in bringing those forward and developing. Even in Frimley, in that evening, I detected a little bit of reticence about whether they were really being liberated to do it, which they were. And it sounds as if they're well on that journey now. So, and when I say clinicians, it's not doctors, and it's not even doctors and nurses. It's doctors, nurses, it's pharmacists, it's allied healthcare professionals, and the solutions amongst all those clinicians. So I think all the clinicians around this table would say very clearly to our clinical colleagues, this is the opportunity for you to come with those solutions in an environment such as Andrew and other integrated care systems are creating, and design and generate the NHS of the future. And that is a key underpinning of the approach that's being taken in the long-term plan.
Matthew, you wanted to respond?
Just 2 points. One is the extent to which this is simultaneously an organisation development programme and how we're going to do performance management and delivery in the future simultaneously is, I think, is unusual. And the organisations that have come together as the ICS have been addressing those issues and how they actually deliver change. And I think the point that Ben made about at some point we're going to need to tell people this is where you're going to, so that because there are difficult things you have to address to get it up and running. This sharing of accountability, the bringing together, the agreeing to cover for each other's financial challenges and work collaboratively is a difficult change to go through. Our best organisations, our best systems got there quite quickly. It is good to see that we have got a whole group who are following after that, but we have some of the country who need the clarity of where this is going to end up in order to bring everybody to the table to solve this. I think it is important. The other thing that I'd just briefly say is I think this programme is addressing one of the NHS's perennial failures, which is how you do spread. How you get innovation spread to other organisations, and the organisations that are sitting around the table, the ICS is sitting around the table, are also kind of recognise a responsibility to solve problems on behalf of the rest of the NHS and support that delivery to the rest of the NHS. And I think using that as a mechanism for getting the early adopters and kind of, in a way, places like Andrews who are always the first to go and do stuff, to actually help places who aren't always the first to go and do stuff do it as well. Because in the end we need to cover 50 million people like this, not just the third of the population we currently have.
I think there's something that Andrew said about creating a movement, and having spent all morning together, I think we're part of that movement, and it's really important that we are role modelling from the centre the behaviours, that empowering of patients and of all of our staff. And I think that's one of the flavours that, as we set clearer terms of engagement, actually you can't substitute the willingness to collaborate and to be part of that movement with some rules. You actually need both, and it's really encouraging to see that coming through. Brilliant. With that,
well, that's a nice segue into the next item, which is how do we model that ourselves? What is it that we do to bring these two organisations together, not by way of any formal merger, which is not legally permissible, but actually to bring into sharp focus, joined up together, the whole panoply of commissioning and provision across the NHS in England. So there are two papers that have been brought to the board this afternoon. I think the second one I'd like to take pretty much as read, which is around what the governance structures would look like, and we've hammered that out pretty much between the non-executives. But the first paper, which I'm going to invite Emily to speak to, is to do with how we develop a common culture between the two organisations and how we drive change that brings us together. Emily.
Thank you, Malcolm. So, a few words to set up this paper. I think it comes at the right point in the meeting, because very much what we are doing in the joint working programme is to change the way that the centre of the NHS works in order so that we can provide improved support and challenge to the rest of the NHS through how we work with STPs and ICSs and devolved systems to which we remain fully committed. So this is all about making sure we reflect what we need to do for the rest of the NHS and make sure we're providing the best possible support into that. So over the summer since we last discussed this, we've made progress on all of the 5 main areas of work that are outlined in the paper, which are outlined in paragraph 23. That is on the operating model, on the culture and engagement that needs to be in place to make that operating model work, on our finance systems and our responsibilities around efficiency, on HR and consultation so that we make sure we work with our people to make this happen, and indeed on implementation. And so over the summer we've shifted the structure of the work in the working programme to make sure we've got that strong focus on how we actually make this operating model operational, focus on the go live activity, whilst we maintain the right grip on the business as usual and making sure we're dealing with the operational and financial challenges that we started the meeting with. And obviously all of that is in the context of the long-term plan, and our work's very strongly aligned with the work of that team, because this is the operating model that's going to help deliver what that team's coming up with. What that means in terms of how this work is progressing is we're trying to answer 3 questions simultaneously and kind of do it in mid-air while we support the NHS every day. The first question is, what are we for as a combined entity? The second question is, where are we going? And that's obviously work the long-term plan's doing for the whole of the NHS. It has relevance for us as a joint enterprise. And how will we get there? So I think in our discussions we've reflected that all 3 of those questions are critical to making sure we end up in the right place. So if I turn to some of the detail around the work that the individual work streams have been doing, the first on the operating model. What you see in this paper is starting to try and tell the story of this operating model as opposed to going through the detail of structures. And in particular in figure 1 and in the description of that over the paragraph 8 onwards, is talking about the relative responsibilities, focus and capabilities of the different parts of the model. One around the national strategy, support and services which are provided to corporate level, one around the regions and what they're responsible for in terms of them being the major locus of decision making and operational work with the rest of the NHS, and indeed with the STPs, ICSs and devolved systems that are represented in the outside of the ring of that paper. So all of those parts have to be working together in order for this operating model to work. And what that's going to take is what we've described along with many other institutions as matrix working, drawing on the expertise of nationally expert functions and the operational relationships and day-to-day working that will be held in the regions. And in paragraph 12, for example, we talk about some of the conditions that are going to have to be in place and some of the changes in our core operating processes. In particular, having a single internal planning process where the 20 people at the centre of this organisation agree what our use of resources will be for the coming year or more than a year. Supported by a flexible resourcing process that means we can get the right people in the right place in the right time to support the rest of the NHS. What needs to happen then in order to support that operating model is we need to recognise that this is a shift in the capabilities and in the behaviours of the people in this organisation. And we know that it's incredibly difficult for people to shift their behaviours and that nothing changes unless the basic beliefs about what we're here for shift. Back to my point about being clear what we're here for in the first place. So we're working in the culture and engagement work stream to think about how do we change the context of this organisation? How do we change the signals that we provide at people every day about what's really important and what we're here for so that we can work in a new, more joined up way and build the right relationship so that we can support the NHS in delivering the right care for patients. And what that involves is changing the systems and processes of the organisation. I've just mentioned a few. Another one is the joint governance paper that Malcolm referenced earlier. It involves building the right capabilities in the organisation. It involves being clear about what we're here for and making that meaningful to everybody in the organisation. And it involves being very clear about what behaviours and priorities we're expecting in our people. And we think that the answer to all of that is already in the organisation. So over the last few months, we've held a number of workshops which have been open to anybody in the organisation to come and tell us what would you like the culture of this new joint entity to be, both from a perspective of what would you like to change about what you experience now, but also, you know, with a blank sheet of paper, what does it need to be like to deliver on the aspirations that we've set out here. And some of the content is summarised at a very high level in the paper. But what's been, I think, very encouraging for all of us is that what we've heard from colleagues in those workshops is very aligned between the two organisations. A lot of people have said to us over the last few months, you know, these are two very, very different organisations. It's going to be incredibly challenging to bring them together. And there are absolutely differences that we have to pay attention to. But actually, the very strong intent of the colleagues in both organisations is incredibly aligned. And hopefully you see that content reflected in the paper. And we've used not only our colleagues' input here, but also the broader system. So we've held a workshop with SDP and ICS leaders. We held a session at the Expo conference at the beginning of September where we invited anybody who was at Expo, so that included patient representatives and frontline clinicians. And overall, that's been about 500 people who've had a chance to give us some input into what this is going to take to make it happen. And we've included on page 7 an outline plan, but which has a bunch of detail behind it that says over the next few months, we're going to run this process of actually really, with the great intent, shifting the culture of the organisation to support improved ways of working. So that by the time we have the structural elements in place, we also hopefully have at least the beginnings of the behaviours that are going to take to make it happen. I was going to summarise the governance paper, but I think, Malcolm, given what you said, I'll pause there.
Good, thank you very much, Emily. Let me invite any questions or comments. Understanding this is work in progress, quite a way to go, but I would pay tribute, I think, to the amount of progress that's been made already. We do start from very different starting points between the two organisations, and what is very clear from the paper is that there's a great deal of common ground in terms of vision and aspiration and golden thread, I think I saw a comment on, but actually still bringing our combined forces together along a single track is going to be quite complicated. Cathy, did you want to come in?
Yes. So, I mean, thank you, Emily, for the paper, and I just wanted to comment that I think it's really encouraging to hear that there is common ground between, you know, more commonality, in my sense is, and the fact that so many people have got themselves involved. I think it's obviously progressed a lot over the last few weeks since we last kind of discussed it. But notwithstanding that, there's clearly a huge effort ahead in order to sort of bring people, you know, changing. We always say how hard it is to change cultures, and with a clear intent about where we want to go. I think you're probably right, aren't you, that the people themselves have got the answers, but
Yes.
we absolutely need to make sure we model the environment in which that can flourish. Otherwise it will frankly fall at the first hurdle. They'll have a lot of expectation which will be dashed because they don't see that. And I think that it's almost incumbent on us right now to pledge that we will, in everything we do from, you know, here on forth, if we haven't already been doing it, then ensure that we are modelling the behaviours we want to see, because it's very easy to dash these things, you know, within all that sort of sense of enthusiasm. So just wanted to say thank you, but there's a lot to do.
Thanks, Cathy. Well, I think the starting point is the existential question of what are we here for, which many of us wonder about every day, but on a personal level. But I think on this, no, I think on this, actually, it's not what we were here for. It's for something greater. It's for something that joins up across the divide and across the silos that we've been having to work across in the past, inefficiently and wastefully. So I do commend this work. I think it's fantastic. In terms of the governance paper, I don't think I need to take that any further. I think everybody's up to speed with that. So I think that brings us to the end of that item. And if I'm right, it brings us to the end of the business. So thank you, everybody, for joining together. I know NHSI has another board meeting now, but from the point of view of this meeting in common, I declare the meeting closed. Thank you.